Hello and welcome back to SimpleMed's Cardiology Lecture Series. My name is Dr Aaron Yip and I am the Cardiology Lead. Today's topic will be on the cardiac cycle. This lecture is aimed at preclinical or phase 1 medical students and allied health professionals, and so is pitched at that level. Let's have a look at some learning objectives. Today we're going to outline the different phases of the cardiac cycle. We're going to look at how the heartbeat is coordinated. We're going to look at how the heartbeat is generated. And we're going to have a look at the physiology of cardiac contraction. The cardiac cycle can be roughly split into two phases: systole, the contracting phase of the ventricles, where the blood is ejected from the heart; diastole, the relaxation phase, where blood is allowed to flow into the ventricles. Whereas the rest of the body is going to receive its blood supply during systole, the majority of the heart's blood supply comes during diastole. This is because during contraction of the myocardium, the coronary arteries are compressed. At around 67 beats per minute, diastole will last around 35 milliseconds, and systole will last around 55 milliseconds, totaling around 0.9 seconds per heartbeat. Duration of systole is constant in all heart rates. Instead, the duration of diastole will change to meet the requirements. For example, during exercise, when the heart rate increases, the duration of diastole will decrease. So how is the cardiac cycle coordinated? Well, the heart contains an intricate conduction system which enables the heart chambers to work in synchrony. At the head of this system, we have a sinoatrial node. Found within the right atrium, this is made of highly specialized cells known as pacemaker cells, which, as its name suggests, is responsible for controlling the pace of the heart, similar to a conductor in an orchestra. An electrical impulse is generated at the sinoatrial node, which spreads across the atria, causing them to contract. This impulse is stopped by a fibrous tissue layer, otherwise known as the cardiac skeleton. This separates the atrium and ventricle, and what it does is it acts as an insulator, preventing the premature contraction of the ventricles. This impulse is directed to another node, the atrial ventricular node. The node is found within the interatrial septum. And what it does is it causes a slight delay in this impulse, around 12 to 13 milliseconds. This allows full contraction of the atria and complete emptying into the ventricles. The atrial ventricular node then sends this impulse down the bundle of His, which along the way splits into two branches, the right and left bundle branch, which is responsible for carrying the conduction to the corresponding ventricles. And at the end of this, they are connected to the Purkinje fibers, which further spread this impulse. The conduction system is formed in a way to allow the ventricles to contract from the apex first, and then upwards to allow maximum ejection of blood, similar to squeezing a toothpaste at the bottom rather than the middle. Should any problem occur in the conduction system, this can lead to arrhythmias in the heart. So how is this impulse generated in the sinoatrial node? Well, the sinoatrial node has the ability to generate intrinsic action potential. This is when the pacemaker cells are able to constantly slowly generate waves of depolarization. This is known as pacemaker potential. And how this happens is sodium ions enter the pacemaker cells via these specialized sodium channels, shortly known as HCN channels. This slow increase in membrane potential is known as the funny current. The membrane potential increases up to the threshold potential of around negative 40 millivolts. The threshold potential is the minimum membrane potential needed to generate an action potential. Once this threshold has been met, L-type calcium channels open, leading to an influx of calcium ions into the cells, causing rapid depolarization. This peaks at around 20 millivolts. The L-type calcium channels then become inactivated, and subsequently the voltage-gated potassium channels open, allowing potassium ions to leave the cell, therefore repolarizing the cell. This lowers the membrane potential back down to the resting membrane potential. Once it reaches the resting membrane potential, the potassium channels close and the sequence begins again. A fact I want to make is that the atrial ventricular node and the Purkinje fibers also have pacemaker cells, which subsequently mean that they are able to also generate spontaneous action potentials. However, the sinoatrial node depolarizes faster than the two, therefore suppresses the two of them. However, in desperate instances, the atrial ventricular node is able to act as a secondary pacemaker. So how is the heart innervated? Well, the heart is innervated by the cardiac plexus, which is a combination of nerves which provide both sympathetic and parasympathetic effects. The sympathetic response is provided by the sympathetic trunk, where neurotransmitters such as noradrenaline and adrenaline bind to beta-1 adrenoreceptors in the heart, which has two effects. Firstly, it increases the heart rate, which is known as a positive chronotropic effect, chrono meaning time, and tropic or tropy meaning change in. Secondly, it is able to increase the force of the heart's contraction, which is known as a positive inotropic effect. Breaking it down again, ino refers to the muscle fibers. The parasympathetic response is provided by the left and right vagus nerve, which creates the opposite effect. So it provides a negative chrono and a negative inotropic effect. Let's follow this initial action potential to the cardiac myocytes. The resting membrane potential of cardiac myocyte is around negative 90 millivolts. Once this action potential comes along, this causes voltage-gated sodium channels to open, allowing an influx of sodium ions into the cells. This increases the membrane potential, peaking around positive 20 millivolts, and they close after that. At this point, some potassium ions leave the cells, and this is known as transient repolarization. Meanwhile, the L-type voltage-gated calcium channels open, allowing an influx of calcium ions and allowing muscle contraction to take place. I will look into the physiology of this in the next slide. Once completed, they close, and then voltage-gated potassium channels open, allowing the efflux of potassium ions and the repolarization of the cells back to the resting membrane potential. The graph below helps us understand how antiarrhythmic drugs work, as there are different classes that affect different points on this graph and help alter heart activity. Let's look at the physiology of cardiac contraction. The action potential reaches the cardiac muscles and travels down the T tubules, which are invaginations of the myocyte cell membrane. This opens the L-type calcium channels, allowing an influx of calcium ions into the sarcoplasm, which are essentially the cytoplasm of striated muscle cells. The calcium ions bind to ryanodine receptors on the sarcoplasmic reticulum, which is essentially a storage container full of calcium ions. This leads to more calcium ions to be released into the sarcoplasm. This process is known as calcium-induced calcium release. The free calcium ions bind to troponin C, which leads to conformational change in tropomyosin, exposing actin and allowing myosin to bind to it, and allowing the sliding filament mechanism to occur, and therefore muscle contraction. Once completed, the calcium ions are pumped back into the sarcoplasmic reticulum, and the rest of it back into the tubules out of the cells. As I mentioned at the start, that the cardiac cycle can be split into two parts, the systole and the diastole. It can be further broken down into 7 phases, and using the Wiggers diagram shown in the image below, it can help us visualize the cardiac cycle. What it does is it allows us to see the changes in pressure and volume within the different components of the heart. The Wiggers diagram typically depicts the left side of the heart, because the right side does not have as pronounced changes since it works at lower pressure. In phase 1, we have atrial contraction. This is when the atria contracts, expelling the remaining 10% of its content into the ventricles. The previous 90% came from the last phase of the previous cycle. When the atrial contraction occurs, atrial pressure increases as depicted on the Wiggers diagram. And at this point, end diastolic volume has been reached. That is the maximum volume of blood in the ventricles before contraction. In phase 2, we have isovolumetric contraction. This is when the ventricles begin to contract. During this, the ventricular pressure overcomes the atrial pressure, forcing the mitral valve to be shut. This creates the first heart sound, known as S1. At this point, the aortic and mitral valve are both closed and therefore blood cannot exit the ventricles, and thus the volume in the ventricles does not change, hence the name isovolumetric. In the third phase, we have rapid ejection. As the name suggests, this is when the phase when blood is forced out of the ventricles, occurring during ventricular contraction. The ventricular pressure is greater than the aortic pressure, and therefore the aortic valve opens, allowing blood to flow into the aorta. At this point, the atrial pressure subsequently drops. Phase 4 follows this when the ejection is reduced and the ventricles begin to relax. The ventricular pressure is still greater than aortic pressure at this point, so blood continues to exit the ventricles. Simultaneously, venous blood begins to return to the atrium. Phase 5, isovolumetric relaxation. This is the start of diastole. Ventricular pressure drops below the aortic pressure, leading to the closure of the aortic valve. At this point is where we hear the second heart sound. During this phase, end systolic volume has been achieved. This is the volume of blood in the ventricles following heart contraction. At phase 6, we have rapid filling. As you may remember, the venous blood is already returning to the atrium. Eventually, the atrial pressure overcomes the ventricular pressure, and so blood is filled into the ventricles. Phase 7 is the last phase of the cardiac cycle. Once the filling reaches around 90% of the maximum capacity, the cycle begins again back to phase 1, atrial contraction, which accounts for the final 10%. And that leads us to the end of the lecture. To conclude, we looked at the different phases of the cardiac cycle, defined the stages of systole and diastole. We learned that the majority of the heart's blood supply comes during diastole. We looked at the conduction system within the heart and how everything is coordinated. Summarizing, the sinoatrial node is at the start, followed by the atrial ventricular nodes, down towards the bundle of His, down towards the Purkinje fibers. We looked at the innervation of the heart and how they control and affect the heart. We also looked at the generation of action potential in the sinoatrial nodes and what happens once this action potential reaches the cardiac myocytes and how cardiac contraction occurs. That is the end of the lecture. Be sure to check out simplemed.co.uk for hundreds of free articles and thousands of free questions and any supportive questions you might need. Thank you for listening and goodbye.